people here. Well, good afternoon, everybody. Dana and Juana, thank you so much for asking me to speak today. Resus nurses, the nurses that are in the documenting, are you sick and tired of getting my notes that asks you, please remember to chart? Have you ever asked yourself, Pat, do you honestly, truly believe that I have time to chart when I've had 8 or 10 recesses? Am I going to remember that? Or are you disappointed or sad that you didn't get a good charting in your inbox? Or for those nurses who haven't even started in the trauma bay, think back and think, thank God I'm not involved in that. I don't have to deal with that. If you've answered yes to that question, I'm talking about the right thing for this class. First of all, I'm going to focus on the Resus Flow Sheet because this is where we look and we focus our data, and this is what I can teach you some things about. And so I'm going to tell you, first of all, who looks at the Resus Flow Sheet? Well, our office, of course, and I'll go into that in a little bit more detail. The trauma registrars, and that is, let me see, I'm going to think of the name, Babette Ortiz, myself, Lori Herman, Carolyn Hanley, and Sharon Root. And what we look at also is the burn service also looks at the flow sheets. Why do you suppose the burn service looks at the Resus flow sheet when there's a burn patient? Parkland formula, they're looking at the fluid, so that's important for important information that they need to know how much fluids you document on the Resus flow sheet. Case managers. Case managers are having to justify more and more why the patient came to a trauma center versus a non-trauma center. So when you document NVA with a rollover, bent the steering wheel, starred the windshield, evisceration of the abdomen, that is ammunition that the case managers have to justify why that patient came to us instead of a non-trauma center. Because insurance companies are looking for any excuse not to pay us. Research staff. Terry Curry and his staff, they're looking at the flow sheet to see if patients meet a certain inclusion criteria for so many studies that Dr. Coimbra and his team are doing here at the medical center. Like I said, insurance companies look at this in detail, not wanting to pay. They'll find an excuse or try to find an excuse. Hospital coders. Hospital coders look at the entire patient's medical record to see where they can bill the insurance companies. So they look for specific information. Also, when we have a site survey, 2 surgeons from the American College of Surgery come and sit and look through about 100 medical records. And what is the first thing that they want to see? The Resus flow sheet. And they dissect that flow sheet like crazy. And you know what? I'm extremely proud to show them that because of your wonderful documentation. Our next survey is at 2015. They'll be looking at next year's data. What is our office looking at? Babette Ortiz and I look at 100% of the flow sheets, and we look at them within about 24 hours of admission. Of course, we don't work the weekends and the holidays, but we're looking for performance improvement, quality assurance. We'll look at your narratives and we'll look to see, for an example, if you're documenting that the trauma surgeon is putting a central line in and your next sentence is chest tube being placed, that alerts us, that tells us, hey, did this guy come in with a pneumothorax or did that surgeon cause a pneumothorax because he put the line in? Deviation of protocols. All our blunt traumas should be having abdominal ultrasound or abdominal CT scan. Did the trauma surgeon or the trauma fellow divert from that? We're looking for that information. Did the patient have a seatbelt sign? Abrasions on their neck? We should see the documentation that the doctors ordered and had the patient have a CT scan of CT angio of the neck. Also, when you document the patient has a liver or a spleen laceration, we're asking the trauma surgeon, what grade is that injury? Because that information goes into our trauma registry. We also look at the trauma attending worksheet in detail. When you document what time you put out the group page, we look at the trauma attending to see what time they respond. They're held accountable to a certain amount of time to be there within patient arrival. If they're not, we're talking to them and finding out why. I've heard a lot of reasons why. One of them, they fell asleep on their pager. The pager wasn't working. Well, guess what? We don't stop there. We actually go and have a discussion or an email with the radio room, the page operating manager, and find out why the physician didn't get the page. We're also looking to see if the trauma surgeon ordered the appropriate consults for the patient. We expect to see an ortho consult if there's a broken bone, or if the patient has a head injury, we should see that they're calling neurosurgery as a consult. We've had a trauma registry since 1984. It's required of all the trauma centers. It's a very, very valuable tool for us. It really tells us as a trauma system how well we are doing, how are we performing, what can we improve on. There are 48,000 patients in our trauma registry as of 1984. I thought that was kind of low, but it is what it is. There are 400 data elements in the registry that we do. Sometimes it'll take us about 30 minutes to do one registry. Sometimes it'll take us 4 days to do one, depending on how many complications, how many operations are performed on the patient. The registry is done at the time of discharge, not of admission, only when they're discharged. This is just some of the data elements that we collect. Pre-hospital information. What was done for that patient before he got here? Did they intubate? What drugs did they give? Did they put them in C-spine precautions? If a patient's transferred to us, what did they do for that patient? Any images, anything that they did, we put that in our registry. And of course, when the patient's admitted to our hospital, we put almost everything in there, from the time that they're admitted to the time that they're discharged. And we put in all operative procedures. We list vent days, any complications, UTIs, pneumonias, anything that happens during the hospital stay. We also put in all injuries. You know, sometimes there's patients who come in, their traumas or they're found down, and all their images are negative, but there's an abrasion that you document on the little trauma image on the flow sheet. We call that an injury. That, even though it's very minor, we call that an injury, and we're able to put that in the registry because you put that on the Resus Flow Sheet. So we really appreciate that when that happens. We also put in our registry, where was he discharged to? Did he die? Did he go to jail, home, SNF? And if the patient dies, we actually get the medical examiner's autopsy, and we go through the autopsy and we list all the injuries that the patient had, especially those ones that came in dead and stayed dead. Who looks at our data? We do. We analyze ourselves. How well are we doing? What do we need to improve on? What can we do better? Where did we go wrong? An example would be this year, how many pneumonias did we have compared to how many pneumonias did we have last year? How many UTIs? This is to be a better trauma system. Where does our data go? It goes to the county EMS, National Data Bank, the Quality Assurance Improvement Program, and the state of California. We submit to the county every month, we quarterly to the other areas. I wanted to share with you an event that happened a couple of years ago. I don't see anybody that was volunteered for the event. A couple of years ago, the county pointed out that there was a peak in motor vehicle accidents with the teenagers because they were texting and driving. I think it was Scripps Ranch, that was that area. And there was about 5 or 6 teenagers that died over several months. So the county told all the trauma directors, and what they decided to do was do an outreach program. And so a lot of the trauma centers, AAA, the police department, the California Highway Patrol got together and planned a day and announced to the public, this is what's going on, you need to be aware of this, and it was outreach and to teach the to teach and educate the public so we can make a difference for the public to reduce that kind of incident in that arena. Nursing documentation for what we all see is really, really good. But every once in a while, we don't get the whole picture. I want to give you an example that I saw not too long ago. We had a patient who came in with a GCS of 15, cooperative, no complaints. Because this patient had LOC, he had to have a CT scan. So the nurse documents, patient cooperative, CT scan, escorted by Dr. So-and-so, has his head CT scan, patient comes back up to the Resus bay, no complaints. Next sentence, patient's intubated, paralyzed, and sedated. And so the first thing I looked at was the GCS. The only GCS that was documented was 15. Then my eyes shift to the left-hand side of the flow sheet. Maybe he had an orthopedic procedure because he had location and they had to put him under. That's what I'm thinking. Nope, nothing there. Then I look at the head CT scan result. It's negative. Then I go to Epic and it says in progress. And so I'm talking to the flow sheet. What happened? I don't have the whole picture. So I ended up talking to the admitting physician, and he said that the patient had a big epidural and had to be intubated and paralyzed. But that did not reflect that in the nurse's documentation. So this picture here, I just kind of want to portray this. Here's Little Red Riding Hood, and she's about to be eaten up by the big bad wolf. If I had the whole picture, you see Little Red Riding Hood has an AKA-47, and the story changes. So that's just a perfect example of how we look at data, and if the charting isn't all there, we don't get the whole picture. I wanted to give you a couple of examples of some documentation. This was a really good one, and the reason why I chose this one, I wanted to share another story with you. And the nurse who documented on this event several years ago is in this room, and I will embarrass that person because it's a good thing. It was a good thing. Several years ago, we had a patient who was at a bar, was drinking a lot, fell off his bar stool, and he had a positive loss of consciousness, came to the trauma bay, head CT scan, was negative, goes to the IMU, and was observed for 24 hours, and the patient was discharged after 24 hours. Several days after he was discharged from UCSD, they found a body down by the river, down in Mission Valley. And the patient had an armband or discharge papers in his possession. Of course, it says UCSD. And so they start calling the administrators, and what's the first thing everybody wants to see? The Resus Flow Sheet. Well, and they contacted the family members. Family members said, we're going to sue. Nobody ever told us he was in the hospital. You know, he's dead. You missed injuries, blah, blah, blah. So they pull the Resus Flow Sheet nurse, documentation sheet, and the nurse very appropriately documented on the sheet, patient does not want family notified of this admission. Okay? So family didn't have a case. The discharge nurse in the IMU documented at the time of discharge, GCS 15, ambulatory, tolerated regular diet, no complaints, discharge instructions given. So when we got the autopsy, the patient had suffered a huge subdural. He was drunker than he was when he first came to admission, but because of the good documentation that these nurses had, the patient's family didn't have a case. Dana, do you remember that case? It was Dana who documented, and because the first thing everybody asks for, even when there's a lawsuit or somebody's being called to court, that's what happens. Do you have the Resus Flow Sheet? So I always like to use that as example. So I hope you can see this. Sometimes times conflict with your documentation. If you see in the, let me see if I can get this here, the time of admission is 7:02. Okay, 7:02. But look what time the nurse puts out the trauma team activation. 07:52. I know you did not wait 50 minutes to put out the trauma team activation. I know that. You would never do that. So when I give you a pink with notes, did you really mean this? please correct it and then correct it on your white copy, because remember, I don't have the white copy anymore. The white copy is part of the medical record. It's a legal document. I only have the yellow and the pink. That's just for our office. So please change that. Here's another one that times conflict. On the admission time, it looked like to me at the time was 16:52. So it makes sense because the trauma team was activated at 16:43. So I'm thinking, okay, well, let's look at that. So the team was activated 16:47 is the time the patient gets here. But look at the first vital sign. The first vital sign is 15:47. So really, the time that the team was activated is wrong. Okay, everybody see that? Okay, it's real important. Okay, now when ACS comes and they look at this, you know, if I have your response on the pink sheet, oh, she really meant this, so that's okay. But if this is not corrected, it doesn't look good for us. We're held to a higher standard because we are a level 1 trauma center. Blanks. Part of our registry a data element is we have to put down what time that team arrived. Okay, that's very critical for us. And on the right-hand side of the screen, I just wanted to show you that's what our registry screen looks like. It's all computerized. So that's a very critical part. So please remember to do that, to document. Perfect charting here on this one here. The nurse documents the patient came from Scripps Chula Vista. Just of a note, sometimes nurses document transfer from SCV. I don't know if that means Scripps Chula Vista or Sharp Chula Vista. So it would help us if you actually wrote Scripps or Sharp. Sometimes we get both. So she charts on this one here that the patient is a passenger, he had LOC, highway speed, rollover. Those are all good words to help not only us enter the information in the registry, but the case manager who's going to justify why this patient came to a trauma center. That's perfect charting. Another case, this entire line with the red arrow is blank. Now, I can look in the logbook and find out what time that patient came and the date. But a year from now, if this case is called to court and the lawyer asks you, Kathy, what day did you chart on this patient? What are you going to say? I don't remember what I did yesterday, much less a year ago. So really, it's very critical. Again, I can put the date on my copy, but again, this is a legal document. And it's also a data element that we have to put in the registry. Perfect charting again, this is another one. This is, let me just kind of see, everything's complete. The nurse documents the time the team was called, what time they arrive, it makes sense. She also puts down the ortho consult. We're looking at the time that consults respond once they're called. They're given a certain amount of time. I'm going to tell you a secret. Neurosurgery and ortho have to be at the bedside or respond within 30 minutes. If they are not, we're finding out why. Sometimes it's acceptable. We talk to the trauma surgeon or the admitting physician and ask, was it okay with you that this guy was not at the bedside within 30 minutes? When you document anesthesia paged, anesthesia paged, anesthesia paged, we're on it. We're finding out what happened. And sometimes it's the pager system. Guess what? We're contacting the paging manager and finding out, because they keep records. So sometimes somebody doesn't tell us the truth, but we already know that. Transfer information. She documented where the patient came from, positive LOC, it was all perfect, it was really good. This slide, I also have a couple of things I wanted to mention. This one is fine, but be careful with your GCS. Every once in a while, I see a GCS that doesn't add up. I just saw one the other day, patient had a GCS of 444 and equals 15. I don't know if you mean 15 or 12. I can't assume. So when I write that on the pink sheet, me or Babette, we write that on there, please correct it. Again, it's a legal document. Mean what you say and say what you mean. Perfect example. Documentation, assaulted by police. Did you really mean the police assaulted a patient, or did you mean it was a legal intervention? The police had to subdue that patient. So be careful how you document that. It's appropriate to say shot by the police or blunt police intervention, but assaulted, that truly means any intentional assault of that patient. I just wanted to show a couple of screenshots of the actual trauma registry. Let's see here, error in judgment, it's up on the top 9008. If the physicians didn't do something for the patient, we're writing it up as a QA item, and the doctors have to answer to that and reply to that. We also have nursing issues. If you document a patient fell out of bed, fell out of the gurney because he wasn't CT scanned without his straps on, that gets put in the registry as well. We also have all our deaths. They're adjudicated as a death preventable, death non-preventable, and death potentially preventable. If you get a chance to go to our select case review conference, this is where those adjudications take place. Delay in physician response, trauma surgeon, like I said before, we closely monitor and look at that, not only of our trauma surgeons or fellows, but also our consults. Other pre-hospital, every time you document that the patient arrived unannounced, that doesn't go unnoticed. And I always CC Juana on this. It goes to the MICN coordinator. She's really good about following up. They know we're looking at that, and it doesn't go unnoticed. And I've looked at these trends, and it seems to have slowed down. Every once in a while, we get one. It might be a brand new paramedic who got lost. Also, if a patient is a no-show, that also gets recognized. I send an email to the base hospital coordinator, and she follows up. Delay in physician response, like I said, consults are looked at very, very closely. Some helpful hints. One of my mentors taught me this a long, long time ago. I know what it's like to have a really critical patient, and you are hanging blood, and you're helping with the airway, you're pushing meds, and you don't have time to chart. I understand that, and really I don't expect anybody to do that because I couldn't do it at the time. So what she taught me, if you write the time that something happens and one or two words that will help you remember what is going on with the patient, so when you have time to document, you can document the entire event. So an example, if I had a patient who started going down the tubes, I would write 22:15 with the arrow down, LOC. And then the next thing that's happening, the patient's intubated at 22:20, ET. And that's all I know. That's all I need for my ticklers to remember to document. So when I do have time, I can say at 22:15, decreased loss of consciousness, unresponsive to stimuli, when so-called anesthesia page, blah, blah, blah. Then at 22:20, intubated by anesthesia, chest x-ray, placement checked, down to CT scan, so you can tell the whole story. So that's what I call ticklers, and whatever is going to work for you, that's a suggestion. If you forget to chart something, you can always take another white sheet, put the date on there, and fill out what you forgot to document. And usually within the 24 hours, it's an acceptable time frame. If you're being subpoenaed because of a patient, or there's a lawsuit involved a year later, you can't go write an addendum. So it's just usually the first 24 hours. Review more senior trauma RN flow sheets. Jeannie and Sandy, I'm going to embarrass you. I always use you two as perfect examples. Very highly experienced nurses, very wonderful and complete charting. Two different styles of charting. So if I encourage the new nurses to look at that documentation when you have time. Some take-home points. Check your charting for blanks. You don't have to finish your flow sheet when you're transferring that patient to the floor or wherever, But when you are ready to complete your charting, check for blanks. Ask yourself, does charting tell the whole picture as to what happened to this patient? Are your times listed accurate and make sense? Did you chart the care that you give? I have another story. A couple of months ago, a patient came in hypothermic. Now, I know warm blankets go on the patient during the Resus phase. She didn't document that. I had to look at the videotape on this particular patient, and they put a warming apparatus on this patient. She didn't document that. So she didn't take credit for what she normally does. And I can't do that, but I think I wrote her a note. I can't remember if I did or not. But she didn't take credit for the care, the wonderful care that she gives anyway. So, does anybody have any questions?